Dri ao Quadrado.
Conversando sobre oncohematologia de forma simples e leve.
Olá, eu sou a Adriana Scheliga e eu tenho aqui do lado a minha amiga Adriana Penna. Hoje nós estamos aqui, o Dri ao Quadrado. Dri, nós temos hoje uma pessoa muito importante participando do evento da Roche do Pulse. Eu queria que você apresentasse ele.
Hoje a gente vai entrevistar o Dr. Dai Chihara. Thank you very much for being here with us.
Appreciate it. Thank you.
We're gonna start talking about. I'm gonna start talking about the Goya trial that you presented yesterday. And when you say that PET is a good tool to predict or to predict relapse, but we still have like 12% or almost 13% of patients who are not, who PET is not a good an option. So how do you think that other tools like ctDNA or other molecular tools can help us bridge this gap that PET still has?
Yeah, so that's the question that field is currently asking. The negative predictive value of PET scan is around 80 to 85%, which means that even though they are negative by the PET scan, if they achieve complete response by the end of the treatment, they have about 15, like maybe even 20% of the chance that they have recurrence of the lymphoma in the future, in diffuse large B-cell lymphoma. So we are now trying to identify these patients before they have radiologic recurrence by measuring the circulating tumor DNA. There are different assays that we have been investigating, from the clonoSEQ, CAPSEQ, and PhaseSeq, and then also recently Signatera platform. We don't yet to have the consensus in what to use to identify these high-risk patients, but there are multiple trials going on right now to identify these patients and then see if we can intervene and then change the outcome, because ultimately finding these patients is not enough. We want to make improvement in their outcome. So we're testing the hypothesis that early intervention before the radiologic recurrence can make the impact in patient outcome.
Ok. Lembrando que o Dr. Chihara trabalha como professor associado do serviço de linfomas no MD Anderson. Professor, I want to know the recent guideline of NCCN update recommends considering ctDNA as assessment as part of the journey of the patient. So I would like to know, in your clinical experience in the MD Anderson, how often does the ctDNA results actually change management decisions compared to imaging or biopsy alone?
So the NCCN guideline is not necessarily recommendation to test the circulating tumor DNA, ctDNA. As we know, there are still limitations in checking the ctDNA. Particularly, there are assays that are not commercially available. So even if you want to order CAPSEQ or PhaseSeq, that's not something we can order in clinic right now. So in our practice at MD Anderson, we have decided that we are not going to use ctDNA for our treatment decision making, but I think it is coming in next few years. We will likely have a platform that we have a consensus to use to guide our treatment decision making. But for now, I don't think we are ready to use the treatment decision making based on the ctDNA.
Going forward, what do you think is our most challenge in diffuse large B-cell lymphoma?
That's a great question. So outcome has been improving dramatically. So since 2002, the R-CHOP has been the gold standard for the last 20 years, and Parallax trial made improvement in 2022. So it took 20 years to show some incremental improvement in progression-free survival. I do think bispecific antibody is a game changer in the field. So most likely that agent will come to the first line treatment. We probably are looking at maybe two different routes. More precision medicine in diffuse large B-cell lymphoma. So diffuse large B-cell lymphoma is a very heterogeneous disease. It's very possible that the one regimen like R-CHOP can potentially cure like 90% of the patients. And if so, we may not need to tweak the regimen, but I don't know if that's achievable. So we want to continue to explore giving the right treatment for the right biology and right patients. So trying to come up with biologically sound combination treatment will be one route that we're exploring. And the other is to optimize the treatment duration or cycle using the tool like ctDNA. So more and more the field is likely leaning towards more optimized cycle, precision medicine based on the biology.
Yeah. In fact, the evolution in the last 10 years was amazing, not only in lymphoma, but also CLL and multiple myeloma. Anyway, and the ctDNA also can capture clonal evolution and identify resistant clones during treatment as BTK mutations like ibrutinib. And how do you envision using serial ctDNA monitoring to guide next line therapies in relapsed and refractory diffuse large B-cell lymphoma?
That's a great question. I think we're not there yet. Currently, the use of ctDNA has been focusing on MRD. So trying to identify high-risk patients who have residual disease. We first probably need to deploy that technology or assay in newly diagnosed case to understand large cell lymphoma better, not like because we do know that there are spatial heterogeneity of the disease. So not by just relying on the core biopsy, we want to understand the entire spectrum of the lymphoma at the time of diagnosis. And then through that effort in trying to characterize large cell lymphoma from the ctDNA, I think this concept of trying to understand the response kinetics or phenotype by checking serial DNA throughout the course. So like, let's say if we start R-CHOP or a 4-RCHP, and not just by detecting MRD, but trying to understand, well, I think it's more important to use that strategy in small molecules like pathway inhibitor to see if there's any mutation like resistant clone coming up. And then we can, make the early intervention to overcome that resistance. But that will take a little longer than trying to use ctDNA to guide our decision making. The challenge is probably the turnaround time, because we do need to have that information in relatively short period of time, right? So right now, the turnaround time of ctDNA can be like weeks to months if you just order it. So that needs to be shorter, because you want to make a dynamic decision making based on the testing. So it needs to come back in like week or two.
I find this new way of looking at lymphomas very exciting, because we used to look at the molecular side of other diseases, and we are not like ready to look at the molecular side of diffuse large B-cell lymphoma. Like we've been doing this with acute myeloid leukemia for a while, and we know that there are different diseases from different molecular perspectives. So I think it's very exciting to finally be able to pinpoint the differences further from only the cell aspect, but the molecular aspect.
No, I fully agree. It's such an exciting time to be involved in the field of lymphoma because there are so many drugs coming out, and also we start to understand more of the biology of the disease. I think these molecular characteristics right now are prognostic, but not necessarily predictive of the outcome, because we start to understand more of the biology, but we don't necessarily have the treatment that fit with the biology. So for like AML and in solid tumors, they do actually have a treatment based on what they can find, right? For lymphoma or the diffuse large B-cell lymphoma, we're not necessarily there yet. We tried to use cell of origin for that, like, stratification of the treatment. Unfortunately, it has failed because it's probably, the large cell lymphoma is more heterogeneous beyond cell of origin. So, but I think we will get there. We do need to have a right, the treatment for different biology. I mean, it's not too far, I think.
And how do you think we can bridge this gap between the bench side and the actual care of the patient?
We discuss this daily basis at MD Anderson. And the critical thing is that the sample collection. So each time point, we need to be meticulous and then really adamant about sample collection, a diagnosis, recurrence, trying to understand what's happening so that we can continue to build the knowledge and come up with the new effective treatment options.
Yes. And to finish, we are now finishing our interview. It's amazing how we evolve. I'm very excited to participate in this meeting because I was on the PI of rituximab with SHOP in the beginning. So it's amazing how the evolution in the last 20 years. So maybe in the future we are treating patients less time, less chemo, and the patient quality of life is the target of the treatment. So thank you very much for your participation.
Thank you.
Thank you. Obrigada, minha amiga querida. Obrigada a todos. Até a próxima.
Thank you.